Hello everyone. In this video we are going to see cephalopelvic disproportion and contracted pelvis. I am Ms. Ruth Kesia, working as a tutor in M College of Nursing. The objectives of this video are to define cephalopelvic disproportion and contracted pelvis, to describe the causes and degree of CPD and contracted pelvis, to discuss the classification of contracted pelvis, to explain the diagnosis of CPD and contracted pelvis, to enumerate the effects of contracted pelvis, to describe the management of CPD and contracted pelvis, to enlist the complication of complex. So next is the pelvis. The types of pelvis are gynecoid, platypeloid, android, and anthropoid. As you see in the picture, the gynecoid, the shape of this pelvis is round shaped. If you look at the inlet of this pelvis, the shape is round shaped. Then platypeloid, it is flat shaped. In android, it is heart shaped. In anthropoid, it is oval shaped. This is the anatomy of the pelvis. So before we are going into the definition of the contracted pelvis and cephalopelvic disproportion. You need to know what is normal pelvis. Okay, so as you see in the picture, the sacrum, the sacroiliac joint, the anterior superior iliac spine, acetabulum, which is a deep cup-shaped bony thing present in the ischium. Okay, so this is the suprapubic angle, which is formed by the two inferior rami of the pubic bone, and the symphysis pubis, the ischium, the pubic bone, the ilium, the large flared shape of the bone present in the pelvis is the ilium, and in the sacrum we have which is a wedge-shaped bone. In front there is a bony projection which is called a sacral promontory. So these are some of the landmarks which is present in the pelvic bone is shown here. So next is the this is the side, the lateral view of the pelvis. Okay, though as you see in the picture, the promontory is given. The diameter between this promontory to the upper part of the symphysis pubis. Okay, the front part which is present near that diagonal conjugate is symphysis pubis. So from the sacral promontory to the upper part of the symphysis pubis is the anatomical conjugate, and sacral promontory to the lower border of the symphysis pubis is the diagonal conjugate. So these are the two main diameters of the pelvic inlet. And pelvic outlet is the diameter between the sacrococcygeal joint to the lower border of the symphysis pubis. So these diameters, the pelvic inlet and the outlet diameters, determined whether the pelvis is adequate or not, whether the pelvis is adequate for the head to pass through during the labor. So according to the this diameters only, we decide whether the disproportion or the contracted pelvis is minor or major. So the diameters of the pelvic inlet and the outlet are very important. As you see in the picture here, there is a transverse diameter, oblique diameter, the anteroposterior diameter. Anteroposterior diameter always from the sacral promontory to the symphysis pubis, and the oblique diameter is from the either sacroiliac joint to the iliopectineal eminence on both sides, and the transverse diameter of the inlet is between the two farthest point between the two iliopectineal line. Okay, this is about the diameters of the inlet which is shown here in the picture. So as you see in the tabular column, it's given the measurements. Okay, usually in inlet the diameters will be like from anterior, posterior, transverse, oblique. It is 11, 12, 13, and the pelvic cavity is always equal on all the sides because it is surrounded by muscles. So anterior, posterior, transverse, and the oblique diameters will be 12. But in outlet, as you see in the picture, I mean in the tabular column, the AP diameter is 13 and the oblique diameter is 12 and the transverse is 11. Okay. So this is about some of the normal anatomy you should know about the pelvis. We have seen. Now we are going to see about the cephalopelvic disproportion. Definition: cephalopelvic disproportion is the disparity in the relation between the head of the baby and the mother's pelvis. It is a pelvis in which one or more of its diameter is reduced below the normal by 1 or more centimeter is called cephalopelvic disproportion. So, degree of disproportion. How we say the cephalopelvic is disproportion. Okay, there is some degrees. It is based on clinical findings and pelvimetry. We say it is severely disproposed when the obstetric or obstetric conjugate is less than 7 centimeter and 7.5 centimeter, then it is said to be severe disproportion. So as I said earlier, there is a diameter in the inlet called anatomical conjugate and the diagonal conjugate. Between these two, we have an obstetrical conjugate. So if that anteroposterior diameter is less than 7.5, then it is said to be severe disproportion. And borderline disproportion when the obstetric conjugate is between 9.5 and 10 centimeter. In the inlet, the anterior posterior diameter is less than 10 centimeter and the transverse diameter is less than 12 centimeter. Then it is called as borderline disproportion. Incidence, according to American College of Nursing Midwives, this cephalopelvic disproportion occur 20 out of 250 pregnancies. Causes are nutritional deficiency, disease or injury to the pelvic bones, developmental defects, a large size baby, abnormal fetal position, problem with the genital tract. Classification, the absolute causes. So absolute causes, here it shows the mechanical obstruction. So this mechanical obstruction may be due to the pelvic reasons like contracted pelvis, anterior sacrococcygeal tumor, or the fetal reasons like hydrocephalus baby or large baby. Okay, this is the mechanical obstruction, and the relative causes are it is mechanical obstructions. It's not going to change, right? This contracted pelvis, anterococcygeal tumor, or the hydrocephalus baby, large baby, we cannot change it. But in relative cause, it can change the presentation and the position. It includes the presentation like brow, face, mentor-posterior, occipito-posterior position, deflexed head, and vertex presentation. So because this may change, we call it as the relative cause. Next is the this is about the cephalopelvic disproportion. Next, we are going to see about the contracted pelvis. The definition is, according to anatomical, it is a pelvis in which one or more of its diameter is reduced below the normal by 1 or more centimeter. In obstetric, we defined it as a pelvis in which one or more of its diameter is reduced so that it interferes with the normal mechanism of labor. So this is about the definition of contracted pelvis. Next is the etiology. Common causes of contracted pelvis are nutritional and environmental defects. So in nutritional and environmental defects, we have minor variation, which is common, and major, which is rachitic and osteomalacic. Rachitic means it is a contracted and deformed pelvis, most commonly a flat pelvis occurring from rachitic softening of the bones in early life. Osteomalacic means the pressure of the trunk of the sacrum and lateral pressure of the femoral heads produce a pelvic aperture that is three-cornered or has the shape of a heart or clover leaf, whereas the pubic bone becomes beak-shaped. And next is the disease or injury affecting the bones of the pelvis. In pelvis, there may be fracture, tumor, or tubercular arthritis. Tubercular arthritis means it is the TB affecting the hip or the musculoskeletal system. The major causes of hip TB are presenting as painful and restricted movement of the hip, and there comes a dilemma of the accurate diagnosis, as several pathologies may mimic this presentation. And kyphosis. Kyphosis is otherwise called the hunchback or the camel's hump. Okay. And scoliosis, it is the lateral curvature of the spine. A sideways curvature of the spine is called scoliosis. Coccygeal deformity, it may be due to pain or infection or injury into the coccyx bone. And Neagle's pelvis, developmental defects like Neagle's pelvis. In what happens in Neagle pelvis, there will be a complete fusion of one sacroiliac joint And absence of development or imperfect development of one half of the sacrum with narrowing of the anterior sacral foramina on the side corresponding to ankylosis, and ipsilateral narrowing of the hip bone and its sciatic nerve. So this is called the Nichols pelvis. The main thing is the complete fusion of one sacroiliac joint. Okay, and imperfect development of one half of the sacrum, narrowing of the anterior sacral foramina. And in Robert pelvis, a pelvis is narrowed transversely due to almost entire absence of the ala of the sacrum. Ala of the or the wing of the sacrum is absent here in the Robert pelvis, so that the transverse diameter is reduced. Next is classification by type of distortion or pelvic architecture. Here you can see the round pelvis. The shape of the round pelvis is round. The gynecoid pelvis is round shaped, and the pathway of the head to travel down is very wide. Okay, and in long or oval, that is the gynecoid pelvis, the pathway the inlet, it is narrowed. If you see in the B classification, in the degree of contraction, the inlet is narrowed but the outlet is somewhat wide. And the triangular or the android pelvis. So if you see in the pathway, the inlet is wide but the outlet is very narrow. And in platypuloid pelvis, the inlet is also slightly narrowed. Okay. Next is classification by pelvic architecture. Pelvis equibiliter justo minor. So this is characterized by general reduction of all diameters equally shortened, usually by 1 or 2 centimeter. Occurs in short women, also occurs in women with massive skeletal bones and developed muscles. The pelvis has masculine features such as narrow sacrum, narrow pubic outlet. Funnel shaped pelvis. Okay. So this is a picture of justo minor pelvis. Next is flat pelvis, reduced anteroposterior diameter with a normal transverse and oblique diameter. Has two type of contracture. Flat pelvis has two type of contracture, simple flat and so first we'll see the simple flat. The entire sacral platform is dislocated toward the symphysis, hence all the anteroposterior diameter of all the pelvis planes are reduced. This is a picture of simple or platypelvic pelvis. Next is a flat rachitic pelvis. Anteroposterior diameter of the pelvic inlet is only reduced. The third one is the generally contracted pelvis. All diameters are reduced, but the anteroposterior diameter are shortened greater than the others, usually connected with the rickets of the childhood. So as you see in the picture, this is the flat rachitic pelvis and generally contracted flat pelvis. Rare forms of other contracted pelvis or otose pelvis develop as a result of inflammatory process in the hip or knee. Beaked rostrate pelvis, under development of both sacral wings. Spondylolithic pelvis, formed due to partial dislocation of last vertebral lumbar vertebra in front of the first sacral vertebra. Osteomalacic pelvis, scoliotic pelvis, only the lumbar region causes the deformity of the pelvis and the acetabulum is pushed inwards on the weight bearing side. So this is a picture of otose pelvis, spondylolithic pelvis, beaked pelvis, osteomalacic pelvis. So this is the important classification, the 4 degrees of contracture. The first degree is true conjugate is less than 11 centimeter, and the second degree is true conjugate is 9 to 7.5 centimeter. In the third degree, the true conjugate is 7.5 to 6 centimeter. Here the spontaneous delivery is impossible. You have to go for C-section. The fourth degree, true conjugate is less than 6 centimeters. So here also the choice of treatment will be C-section. But in first and second degree, the spontaneous delivery is possible. So how to diagnose this contracted pelvis or cephalopelvic disproportion? First is rickets. First is history collection. You have to ask the mother whether she has any delayed walking and dentition. Okay. Then if at all present, then you have to suspect for any rickets or trauma or disease of the pelvis, spine and lower limbs, infantilism and previous tuberculosis of bones and joints. And you have to ask for bad obstetrical history, like prolonged labor in the if at all the mother had a previous labor. You have to ask whether there is any prolonged labor, whether there is any forceps used, cesarean section or stillbirth. You have to ask for the weight of the baby, or you have to check for the maternal injuries such as perineal tear, vesicovaginal fistula and rectovaginal fistula. Okay. These fistula may be present only if they use any forceps or vacuum during the delivery. Okay, it means the spontaneous delivery was difficult and they had to use some force. Okay, and this history you should be collecting. Next is abnormal gait. Assess the woman for stockily built with the bull neck, broad shoulder with short thigh, obese and male distribution of hair. Stature, the woman, if the woman is less than 150 centimeter or less than 5 feet, that should be noted. In abdominal examination, you have to look for pendulous abdomen in primary gravida. Fetal head fails to enter a contracted pelvis at the end of pregnancy and floats high above the inlet. Failed growth of uterus deviates upward and anteriorly. Non-engagement in last 3 to 4 weeks in primary gravida may suspect for cephalopelvic disproportion. See, there are two shapes of abdomen, that is pointed in primary gravida with a resilient abdominal wall, and pendulous abdomen in multiparous. Next is the abdominal method in CPD. So this is about the history collection. Next is the physical examination. First, in physical examination comes the palpation method. The first is the abdominal method in CPD. How to find the cephalopelvic disproportion by palpation. Place the patient in dorsal position with thigh flexed and separated, and head is grasped by the left hand. Two fingers, the index and the middle finger of the right hand, are placed above the symphysis pubis to note the degree of overlapping if when the head is pushed downward and backward. So as you see, with the left hand, they are holding the head of the baby. With the middle and the index finger, it's placed about the symphysis pubis. Okay, by holding the head of the baby, you have to push the baby backward and downward. Okay, and see whether there is any overlapping of the symphysis pubis with the parietal bone. This is how you test the cephalopelvic disproportion by abdominal palpation method. If the head can be pushed down into the pelvis without overlapping of the parietal bone and the symphysis pubis, then there is no disproportion. If the head can be pushed down a little bit, but there is slightly overlapping of the parietal bone evidenced by touching on the undersurface of the finger, overlapping by 0.5 centimeter, then it is called moderate disproportion. If the head cannot be pushed down and instead the parietal bone overhangs the symphysis pubis, displacing the finger, then it is called a severe disproportion. Sometimes the degree of disproportion is difficult to calculate by this method because of deflexed head, thick abdominal wall, irritable uterus and high floating head. If at all these cases present, you may not be able to do this test. So next is the abdominal and vaginal method. So first we saw only the abdominal method. Here comes the both doing the abdominal palpation as well as vaginal method. It is also called Muller-Monroe method. It is a bimanual method. Same way, the head is grasped by the left hand, the parietal bones, or the head is grasped by the left hand, and to the right hand with the index and the middle finger, we do a pervaginal examination to see the overlapping of the parietal bone over the symphysis pubis. The results, if the head can be pushed down to the level of ischial spine, then there is no overlapping of parietal bone over the symphysis pubis. That is called no disproportion. If the head can be pushed down a little bit but not up to the level of ischial spine, then there is a slight overlapping of the parietal bone. Then it is called moderate disproportion. And the head cannot be pushed down. Instead, the parietal bone overhangs the symphysis pubis, displacing the thumb. Then that is called severe disproportion. So this is about the palpation method, that is abdominal palpation as well as abdominal and vaginal palpation method. Next is the clinical pelvimetry. how to calculate, how to diagnose the cephalopelvic disproportion by clinical pelvimetry. So in clinical pelvimetry, we have internal pelvimetry, external pelvimetry, and imaging pelvimetry. So what is pelvimetry? The pelvimetry usually measures the the diameters of the pelvis. Okay, the anteroposterior, the oblique, and the transverse diameters of the pelvis, and to determine whether the labor can be possible through vaginal delivery. Okay. And the internal pelvimetry, we do the pelvic examination and find out all the diameters. How much is the diameters, the anteroposterior diameter, okay? And we can calculate the inlet cavity and the outlet diameters by pelvic examination. In external pelvimetry, the we use a pelvimeter. Okay, it is a device used by the obstetrician physicians. It is a steel pelvimeter, externally measures the pelvis and assess the size of the birth canal to assess how far or along a labor was. And this is used to evaluate the external obstetric pelvis diameters in shifting position. So it is a manual examination using a simple instrument. In imaging pelvimetry, we use the X-ray, computerized tomography, and magnetic resonance imaging. Through that, we measure the all diameters of the pelvis and decide whether it is adequate for the normal vaginal delivery. So this is a clinical assessment of the pelvis. So this is about the history collection and physical examination and the diagnostic studies. Next is the effects of the contracted pelvis. So in management, if the disproportion is moderate degree and severe degree. If it is moderate, then there can be preterm labor or term labor. If it is preterm labor occurs, then we can go for induction of labor. If the labor is during the term, then there can be either trial labor or directly cesarean section. So what are the reason indications to directly go for cesarean sections or major degree of contraction, major disproportion, absolute contraction, dead fetus, and patient not fit for trial labor. So in this condition, we can directly go for cesarean section. So the emergency indication would be when the trial labor is failed. The next is going for the trial labor. When the mother is in term, we can go for trial labor. It is the conduction of spontaneous labor in a moderate degree of disproportion in an institution under supervision with watchful expectancy, hoping for a vaginal delivery. Or trial of labor is a test of labor allowing the patient to enter into active labor, putting all variables like power, passage, and passenger into test and determine whether vaginal delivery is possible or not. This is called trial labor. So how to conduct a trial labor? Careful fetal and maternal monitoring by electronic fetal monitoring and non-stress test. Oral feeding remained suspended and hydration is maintained by intravenous drip. Adequate analgesics is administered and augmentation of the labor by oxytocin. So the progress of the labor is mapped with the photograph. We have to mainly monitor the progressive descent of the head as well as the progressive dilatation of the cervix. After the rupture of membranes, pelvic examination, the pelvic examination is to be done to monitor, to find out, to exclude the cord prolapse, to note the color of the liquor, to assess the pelvis once or more, to note the condition of the cervix, including the pressure of the presenting part over the cervix. In favorable cases, the trial labor ends spontaneously with the low forceps and the low ventose. In unfavorable cases, we have to go for a cesarean section. What is the successful trial labor? A trial is called successful if a healthy baby is born vaginally, spontaneous, or by forceps or ventose with the mother in good condition, okay, without any perineal tear or something. And if the failure of trial labor, delivery is by cesarean section or delivery of a dead baby spontaneously by craniotomy is called a failed or trial labor. What are the advantages of trial labor? Lower incidence of cesarean section. Successful trial ends the woman in a good future obstetrics. Disadvantages may end before full cervix dilatation, increased fetal mortality and morbidity. In failed trial, operative risk increases. diagnosis. Nursing management or check the vitals every 4th hourly, monitor both contraction and fetus continuously, report immediately the signs of fetal distress, position the mother in ways to increase the pelvic diameter such as sitting, squatting which increase the outlet diameter and also aid in fetal descent, assess the fetus for hypoxia, provide support to the client and the family members in coping with the stress of a complicated labor. Complications or during first stage there can be fetal distress and prolonged labor. During second stage there can be delayed second stage and shoulder dystocia. And third stage there can be retained placenta, PPH and maternal injury. So this is about the complications. We have from first we are seeing about what is CPD and contracted pelvis. We saw the normal anatomy of the pelvis, the diameters of the inlet, outlet, and the cavity, the types of pelvis, and we saw what is cephalopelvic disproportion. Okay, the degrees of cephalopelvic disproportion, contracted pelvis, the causes of the contracted pelvis, and classification of this contracted pelvis. How to do history collection, physical examination by abdominal method, the vaginal method, and clinical pelvimetry, and how to manage this complications, the cephalopelvic disproportion by trial labor and cesarean section, and we saw the nursing management and the complications. I hope you gained some knowledge about the cephalopelvic disproportion and contracted pelvis. Thank you. We'll see in the next video. Thank you.